everyone, and welcome to another episode of The Wealth of Health. Today, we're talking about menopause. A lot of our female clients tend to ask us a lot about menopause, perimenopause, hormone replacement therapy, and those questions keep coming. So there's an evident lack of information and guidance in the public domain. So we actually collated most of these questions, and we're going to try and answer them on this episode. With me, as always, is Dr. Paul Jenkins, consultant physician and endocrinologist.
Thank you, Ahmed.
This is more of your area of expertise because you specialize in hormones.
Yes. No, I prescribe a lot of HRT and answer a lot of these
that's gonna
questions, a lot of the time.
Great. So these are the most common questions, and it's actually very surprising that something that every single woman is going to go throughout the duration of her life,
Mm.
and there's not enough information about it. There's not enough guidance. There's not enough awareness. So hopefully we'll address some of that today. I mean, I collected some basic questions and some very specific questions, I guess.
Yeah.
Let's start with question number one, which is what is menopause?
Well, the menopause is when the ovaries begin to fail. Yes, and the ovaries produce female hormone estrogen, and in sort of middle age, they tend to stop, or they gradually stop working and stop producing estrogen. So the menopause is the ending of the functioning of the ovaries and the loss of estrogen.
Okay. And so it's when the ovaries stop working, that's not in itself an issue. It's the fact that they stop producing estrogen that is the issue.
Yes.
Or that's what causes the symptoms.
Yes.
Okay. What are those symptoms?
Okay, well, some women have no symptoms. So someone's just sailed through the menopause and doesn't seem to bother them at all. In general, menopause is probably 45 to 55 in that sort of age. Now, it can be earlier than that. Occasionally, it can be later. But that's the vast majority of women will start to go through the menopause at 45.
Is earlier is what is called the perimenopause.
No, well, the perimenopause we can discuss is slightly different, but
Okay.
you can have premature menopause, which affects women at a much younger age. So, it's rare. Fortunately, it's rare, but it can happen.
Okay.
But of the symptoms, probably the most common is hot flushes. Yes, vasomotor. We call it vasomotor instability. So you get hot flushes out of nowhere with no particular reason. You're just sitting down, often just relaxing. You get a wave of overwhelming hot flush and sweating. They get the night sweats. So it's particularly bad at night. So women often have to sleep with very few duvets. Their partner then is shivering because they're not having hot flushes. You get sleep disturbance, is quite common. The loss of estrogen results in vaginal dryness, so that can be an issue, and you get reduced libido and sex drive. And then very common are the mood changes. So firstly, you can get changes in memory. The memory gets worse, and then mood. People become more anxious, can become more irritable, low mood. So it's quite a constellation of symptoms.
And every woman experiences those symptoms differently or with different intensity for every one of those symptoms.
No. So some women, as I said, you can sail through it. They hardly notice it. All they notice is that their periods have become more regular and then stop, but they have none of these symptoms. Yes. Whereas other women, these women can be absolutely life-changing, and really debilitating to them. And some women, as with all diseases, the symptoms can vary from person to person. So this is the range of symptoms that you can get, but not everybody will suffer every symptom, but they can get them to varying levels.
And I guess the disease is not the actual menopause; it's the lack of estrogen.
Yes, but I mean, I think you mentioned earlier, Ahmed, it's not a disease.
Right.
This is a natural part of now that evolutionary we are all surviving much longer. So it is the natural part of the aging process.
Okay. Um, and so are there then physiological changes that happen? Well, obviously there is in the body, but do they present risk factors for developing certain diseases as well?
They certainly can do. So, you know, the most important probably is development of osteoporosis, thin bones. Yes.
Thin bones.
Yes. So with a loss of estrogen, yes, within the first 2 years of the menopause, 2, 3 years of the menopause, can have quite a rapid loss of bone density. So it's the onset of osteoporosis. Yes.
Okay. And
So
again, everyone experiences that.
not at all. No.
Some women
Yes.
experience it, some don't.
Yes. Yeah.
Okay.
And then, you know, there are other risks that it can probably increase, and it's still controversial. You may be aware of it, about the risk of heart disease in women and HRT.
Mm.
But we know that after the menopause, the risk of heart disease increases significantly in women. And then
Wow.
indeed, I think we've mentioned before, it's a really important factor that coronary artery disease in women postmenopause kills more women than breast cancer. It's a really important fact that women, and there's fortunately starting to be some more medical acceptance of this knowledge of
Mm.
the importance of it, and for detecting heart disease in women, which presents differently to men with different symptoms. So doctors need to be aware of it and consider it when women can
Mm.
present with rather atypical symptoms.
And I guess, and this is actually a question from some of our clients. Okay, they started experiencing some of those symptoms. Now what? What should they
Okay.
do?
Well, you can have, and it's very real phenomenon, is the perimenopause. Yes.
Right.
So this is probably the period for 1, 2, 3 years before the actual menopause. Yes.
Mm.
When the periods become slightly more irregular, they can change either in duration or flow, and then they slowly, you know, the ovary slowly stops working so much. We
Right.
can call it, we used to call it the winking ovary. Yes, it sort of splutters.
Mm.
Yes, it's like your car running out of petrol. It splutters, it keeps going, you get 1 or 2 periods, it becomes slightly irregular, and then it stops for a month or two, and
Right.
then kicks in again, stops, and it slowly wanes.
Mm.
And in the perimenopause, in the times when you don't have sufficient estrogen, you can get the symptoms.
Okay. So is there a case to be made that if women start to experience perimenopause, if they see a doctor and get on a treatment plan, then they might circumvent or avoid the full-on symptoms of menopause?
Absolutely. Yes.
Right.
Yes. And you can determine very straightforwardly with blood tests whether you're going in the perimenopause.
Okay.
Yeah. The ovaries are controlled, like all the glands in the body, are controlled by the master gland, the pituitary gland,
Mm.
which is a tiny pea-shaped gland at the back of underneath your brain, a couple of inches back.
Right.
Yes. And that sends signals to the ovaries telling them to work. The two one's called luteinizing hormone, or LH, and one is called FSH, follicle stimulating hormone. They control the function of the ovaries, the natural cycle, ovulation. But in the menopause and the perimenopause, as the ovary stops working
Mhm.
and the level of estrogen reduces, the pituitary gland senses it, and the levels of the LH and especially the FSH go up, because they're trying to whip a failing ovary.
Right.
And so if you measure the FSH level, you can see that it's starting to increase
Increase.
significantly, and that's biochemical proof, endocrine proof, that you're starting to go through the menopause.
So it's a simple blood test.
It is a simple blood test, yes.
Okay. So let's say the blood test confirmed that, someone is at that stage. Now what?
Then it's appropriately, and really appropriately nowadays, it's an informed discussion between you and your doctor as to whether you might want to start HRT and which form of it. And the
Okay.
HRT is the R, hormone replacement therapy,
Mm.
because you're trying to replace the amount of estrogen that your body is now no longer producing, which will then restore you back to how you were before and avoid any of the symptoms of estrogen deficiency.
Hormone, that's quite controversial.
It is.
There's a lot of pro talk and there's a lot of against.
Because,
Uh,
as always, people take very polarizing views. Yes. When I started
yes.
in endocrinology, every woman when they went through the menopause was automatically just put on HRT. HRT, don't discuss it, just take it.
Wow.
Okay. Then the pendulum swung all the other way, and it was thought to at times be the devil's work, and no one should be an HRT. A lot of concerns about breast cancer and heart disease. And now, fortunately, appropriately, has come back to the middle ground, and it's a personalized discussion for you, to make your own assessment, because it depends on your symptoms, on your risk factors, on what you want, presence or not of osteoporosis. So there's a whole variety of factors to appropriately take into account. And that's the same with virtually all medicine. It's having a proper, nice discussion with your patients, informing them about it, and you come to a joint decision.
So the question is, the HRT or the hormone replacement therapy, is there to make the symptoms of menopause milder, or is it there to prevent development of serious life-threatening disease?
You could say both.
Okay.
Yes. I mean, if you're symptomatic, you're going to relieve the symptoms. Yes, by taking some HRT in the appropriate doses. It can also, prevent the development of osteoporosis, which you wouldn't know anything about. It's asymptomatic disease until you fall and you have a fracture your hip, or have you become shorter because your vertebra collapse.
Right.
And potentially it can reduce your risk of heart disease.
Reduce the risk of heart. Okay. So it all sounds positive to me. What's not so positive about HRT?
Well, some women just don't want to have, and appropriately, if that's their decision, don't want to take what they perceive to be chemicals or
Right.
medications.
Right.
Some women are, and are concerned about the risks of HRT.
So let's talk about the risks.
And there is, a small increased risk of breast cancer, uterine cancer, cancer of the womb, and ovaries. So those are factors which you need to take into account if you're prescribing HRT or considering it. If you had a very strong family history of breast cancer, you may not want to take HRT. But equally, I would say, it's part of the informed discussion management plan, yes, but every woman should be having regular mammograms to screen for breast cancer.
Right.
And you should consider having, if you're able to, a regular pelvic scan, ultrasound scan, looking at the ovaries and the uterus.
Okay.
This is part of, to my mind, basic MOT as you get to a certain wise years.
That sounds a bit scary, though, because in order to reduce the symptoms of menopause and maybe lessen the risk of potential future heart disease, you increase your risk of cancer.
It's a small increased risk, but yes.
What's small?
Well, the studies, it's not absolutely certain the degree of risk, but it's, in the region of absolute risk of perhaps 1%.
Okay. And does that mean that every single person who goes on HRT has an increased risk of 1%?
Well,
or some people can be on it for the rest of their life
absolutely.
and not have?
Absolutely, yes. Yes. And we can't always predict those, but you've got to, that's why I would say advocate the regular screening. Yeah, mammography. There's also, if you take all estrogen, particularly the tablets, there's a slight increased risk of blood clots, similar to young women on the pill. The
Right.
pill is also a form of estrogen, yes, but it's a much higher form of estrogen
Okay.
in what we call pharmacological doses, yes. Whereas HRT is what we would call physiological doses. You're trying to mimic the natural secretion, not push it too high.
Because you're replacing that
You're
with the R
replacing.
you mentioned. Okay. Because there was this episode on Panorama, I think, a
There
couple
was,
of weeks ago,
yes,
and there was a lot of discussion around HRT and the
doses.
dosage and all of
Correct.
that. Okay, so what do you make of that?
Well, in my mind, you can't, it's not the dose that you're prescribed that is important. Yes, it's the level of estrogen that it results in. Yes,
Right.
so it's easy to measure circulating estrogen level for the vast majority of types of HRT, because it depends slightly on the form of estrogen you're given. But for the vast majority of them, you can measure circulating estradiol levels, and you just titrate the dose that you need to take to reach the certain level. It's analogous to my mind with my thyroid. You know, I do a lot of thyroid disease. Some people need a tiny dose of thyroxine replacement. Some people need a massive dose. Yes,
Right.
but that's what they need to get their blood levels in the middle of the accepted range. And we know roughly what, you know, it's a fairly broad range, but what is an acceptable circulating estrogen level in the blood. So you just adjust the amount of HRT that you need to reach that level.
Okay. And what if some women don't want to have HRT? Is there an alternative for them?
Well, it depends very much on the symptoms that they're suffering with.
Mm.
Yeah, so if it's hot flushes, you can potentially use some medicines which can sometimes help a little bit with the hot flushes. Not always that effective, but can do.
Mm.
If it's mood changes, then yes, you can consider forms of antidepressants, or which change the neurotransmitters in the brain, which can help with the mood. If it's bone and you're concerned about the bone density or osteoporosis, it's calcium and vitamin D, and then specific medicines that slow the rate of bone loss. So again, it
Mm.
depends a little bit on what you want. I would say probably that also in HRT now, one of the symptoms is a lot of it is quality of life, but is libido, sex drive, and it's quite increasingly common, and certainly in my practice, to also measure and offer a tiny replacement dose of testosterone, which helps with
For
that
women.
aspect for women.
Okay.
Yeah, so you have estrogen. If you still have a womb, still
Mm.
have the uterus,
Mm.
you need the progesterone to counter the effects of estrogen on the lining of the womb, because otherwise you have increased proliferation of the lining of the womb and increased risk of cancer.
Right.
So you need the progesterone, but then you give a little whiff of testosterone. The easiest way now is a tiny gel. It's an alcoholic gel that you just rub onto the thigh, tiny blob, size of a petit pois pea, and that can bring the testosterone level into the mid-normal range, help a lot with energy and with sex drive and libido.
Fantastic. Well, what about the risk of heart disease? Is there an alternative to HRT to reduce that risk?
Where you would then have, we've discussed in a previous episode
Mm.
about individualizing or stratifying your personal risk of heart disease by ideally the means of a CT scan of your coronary arteries.
So you would say, just in order to be, from the knowledge of me as a patient or any woman as a patient, when you go to the doctor, you need to establish a baseline before you start anything. So
I
do a
do
blood
that.
test, see where all the levels are at, and then act upon it.
Yes.
Okay,
Yeah.
and that's what all doctors essentially should be doing.
Well, that is my practice. I can
Right.
only probably base it on mine. I like patients to be informed of their health and to have as much accurate, high quality information, data
Mm.
as possible, so it helps them make an informed decision as to what they want to do. Because it's not me taking the medicines. I might recommend it, but it's you or the patient who's going to be taking these,
Mm.
and who needs to be aware, or in my opinion, should be aware of why they're taking it, and is it going to do them benefit?
So from a very generic question, would you say that HRT is relatively a safe practice?
Yes, yes. And for many women, it transforms their quality of life. They feel much better on it. But equally, I'm not evangelical about it, because as I mentioned, it depends. Some women aren't bothered by the symptoms.
Right.
So if you,
So
and
they shouldn't be on it.
no, no. And some women, if that's their decision, they don't want to do it because they just don't want to take a medicine, absolutely fine.
Mm.
It's a woman's decision. My job is to give you the information that you can make your informed decision on, and then we'll act on that.
Okay. I mean, one last question, I guess, because the symptoms is what everyone hears about the most, right?
Mhm.
And you explain the hot flashes and the mood swings, but what is physically happening in a woman's body that is triggering those symptoms? Is it just the lack of estrogen?
It's the loss of estrogen.
That's
And
it.
then for the hot flashes, we call it vasomotor instability, the nerve control of the blood vessels.
Mm.
Suddenly the blood vessels dilate and you get whoosh. That's the cause of hot flush. So if your blood vessels dilate under your skin, you suddenly get increased blood flow through the skin. It increases the temperature. You can see when somebody is blushing, there's increased sudden of the blood flow, and that's similar to the cause of the hot flushes.
Okay. And the mood swings?
Many hormones influence how we feel.
Mood.
That's one of the things I still find fascinating about endocrinology, is how it changes us all, and the neurocognitive and the changes in the neurotransmitters which influence how we behave, how we think, how we feel. Yes, and the mood. And the changes in the estrogen can certainly play a major factor in that.
How can I be informed, or how can our female clients be informed enough when they go and have this discussion with the doctor, they understands what tools they have in their toolbox, or the basic understanding
Yes.
of the whole process, so that they can have an informed decision rather than just the doctor says this, okay.
Yes. Well, I hope this podcast will have helped clarify some of the myths and answered some of the common questions. It's to have a discussion with the doctor on the pros and cons of HRT and your symptoms, and whether. And again, I would suggest that just because you start HRT doesn't mean you're committing to it indefinitely. You start it and you see which type suits you, see if it's helping with your symptoms, how you're getting on with it. And then if it doesn't, you either try a different form or you say, no, this isn't for me. So there's not one size fits all, and there are a variety of different forms of HRT. It can be the tablet. Yeah. It can be the tablet, but as I mentioned, can be associated with an increased risk of blood clotting, so tend not to. The one we tend to use the most is either a patch, which is you apply twice a week, which releases estrogen through the skin, or my personal preference is a gel, which is a clear alcoholic gel. You rub 1, 2, 3, 4 pumps on, depending on your levels and your response, at night onto the thigh, with or without a tiny whiff of testosterone I mentioned. And you take the progesterone in the form of an identical form of progesterone, which is the same as your body makes, either a tablet or the Mirena coil, which is a IUD coil, which has an amount of progesterone, which is released very, very slowly, and that protects the womb. So there are different formulations of it, depending as to your preference.
Vitamins, because we always talk about vitamins.
Yeah.
So when the menopause happens, is there a sudden drop in a lot of vitamin levels, or not necessarily?
No, you can be low in vitamins any time. I mean, I think that most people are not low in vitamins. The only one they tend to be low in, and almost all of us are low in, especially in the UK, is vitamin D.
Right.
And it's a sunshine vitamin. The vast majority of it is through sun exposure and UK weather, and many of us in sedentary jobs, you're not sunbathing. So everybody, in my opinion, should certainly have their vitamin D level checked, and then be on appropriate doses of it.
And that also, vitamin D also affects the mood?
It can definitely affect the mood. But I think, I hope that's clarified a lot of the issues and some of the questions from our viewers. But I think, we should hear an alternative view other than just me.
I think so. We are delighted to have with us Dr. Claire Phipps. Dr. Phipps, welcome to the Wealth of Health podcast.
Thank you. Thank you for having me.
It's a pleasure. Dr. Phipps, you graduated from Guy's, King's and St. Thomas Medical School, and you also hold a degree in human biology. And throughout your career, you've gained expertise in treating a wide range of medical conditions, including women's health, which is the topic of our discussion today. Outside of your clinical work, you deliver menopause workshop and podcasts and advocate for community health initiatives to enable all women to receive the care they deserve. So you are definitely the one to speak to.
Let's hope so. Yes. Thank you.
Fantastic. So we've gathered some questions from our female clients about menopause, and please feel free to provide as much information as possible. I'm going to dive straight through them. This is how they were sent to us, so I haven't edited them or anything. Question number 1, do genetics play a part in it? If my mother or grandmother had a hard time with it, does this mean I will too?
And will I go through the menopause at the same age as my mother and grandmother?
So lots of questions in that, just one simple question.
Yes.
So the simple answer is we think that genetics probably do play a role in when we are going to achieve menopause, or when we get to that kind of point in our life where we've had our last period. That's probably only part of the story. We know that genetics obviously play a big part, but we also know that lifestyle and environment also play a big part. So we're thinking about pregnancies, how many pregnancies we've had, if we've breastfed, what is our lifestyle like? Are we a smoker? Do we consume a good diet? Are we consuming a lot of alcohol? All of those lifestyle practicalities, I guess, have a really big part to play in when we might have menopause. But we do know that there are genetic tendencies, particularly in women who have an earlier menopause, or particularly in women who might have premature ovarian insufficiency. And that tends to run in families, certainly just from a genetic perspective. So it doesn't naturally follow that if your mother or grandmother had their menopause at the age of 51, you are automatically going to have that. Of course, it doesn't. But actually, we do know that there are similarities that follow suit. However, we have to kind of think about you very, very holistically. And, whilst we look at the genetics and we think about your family history, it's not the only thing that plays a part.
Okay. Second question is, what can women do to help prepare their body for menopause? And this is advice for women in their 20s, 30s, and 40s.
Yeah, this is a really good question, actually, because what we want to be doing is we want to be empowering ourselves from an earlier age in the same way that we do about periods, about contraception, about getting pregnant, not getting pregnant, for example. We want to also be learning about the other stages of our life earlier. And there's lots of reasons for that, because the menopause brings with it changes to our physical health and changes to our long-term health. So, for example, we know that peak bone mass is in our 20s to the late 20s, early 30s. We know that that's when we achieve the best bone density, the density of our bones. And after that, it begins to drop off. Yes, very slowly, but it does begin to drop off. So what we want to be doing is preparing ourselves actually in our mid 30s, ideally. What we want is we want to have good bone density. So we want to be making sure our lifestyle and our nutrition and our movement are as optimized as they can be. And obviously, I say that with a pinch of salt because we're not all great at doing it. But it's really important that we try to focus on eating well. And by that, I mean eating the rainbow, getting your 2 to 3 portions of oily fish a day, eating a Mediterranean diet, incorporating lots of fruits and vegetables if we can, herbs, spices, fermented foods, all of these foods that can build good gut health. Those are the things that we can start doing early. And not only will they help our kind of current health in our mid 20s and 30s, but they'll also benefit us in the long term. And if we can get that as normal, rather than trying to achieve, oh, I must eat this certain thing. This is what we want to be habit forming. So this is what we want. That will also help with our longevity, will also help protect our bones, our heart, and our brain. The other spectrum to that is just becoming aware, becoming educated about the fact that our hormone levels will change as we approach our 40s, mid 40s. And there are lots of things we can do about that, but also knowing what symptoms could possibly arise sometimes makes those symptoms more easy to manage. So empowerment and knowledge can be really helpful.
Thank you very much. I mean, the next question really follows from the first one. It says, what food, drink, exercise can help women during the menopause?
Yeah, so really another really great question, because actually what we think about as menopause is there aren't any quick fixes. We know that there are lots of treatments available, but what we want to build on is a good foundation of health. And for any condition, that is lifestyle, that is movement, that is diet. So in terms of food, again, we want to be eating the rainbow. We want to be really focusing on a Mediterranean diet. That's not to say don't succumb to the chocolate and the sweet things and the things that are bad to us, because actually we get enjoyment out of food. So we want to enjoy our food, but what we want to be trying to achieve is some sort of balance, isn't it? So maybe sort of 70% good, 30% bad, tipping into the 80% good, 20% bad. So what we want to be doing is really thinking about incorporating all those fruits and veg, all the proteins, the lean proteins, and the lean proteins that will build muscle and help us to stay fuller for longer, so we're less likely to snack. And those are really key. And those things, certainly as we approach the perimenopause, can be really helpful for symptom control. So the other sort of spectrum, when you're in the perimenopause, we know that sort of typical symptoms like hot flushes and night sweats can get worse with things like caffeine and alcohol or spicy foods. So trying to reduce that if you can be helpful to control your symptoms. Increasing your fluid intake is really important, particularly if you're someone that's suffering from what we call vasomotor symptoms or hot flushes, because you do lose a lot of fluid from those. So making sure you're hydrated makes you feel better generally, makes you less constipated and makes you more alert. So simple things are often the best. So a really good balanced diet essentially is what I would aim for.
And for exercising, is this the normal? What would you recommend? Is it the normal cardio, or would you recommend more weights actually, so more strength training? What's your view on
Yeah, yeah.
exercise?
So I prefer to use the term movement than exercise, because I think exercise comes with it lots of negative connotations for a lot of women who've been assigned female at birth. So I try to think about it as being movement. And in our 20s and 30s, many of us are very good at that cardiovascular high intensity training, which serves us really well at that point, and our bodies can cope with that stress and strain. As we progress through the perimenopause, what we are looking for is less cardiovascular. We still want our heart to be healthy, but we want the strength training and resistance, because that will build bone and that will build muscle strength. And muscle strength is really important as we progress through the perimenopause. As our hormone levels change, we lose muscle mass and we can be prone to weight gain. So if we can try and increase resistance training and strength training at that point in our life, that's really helpful. Power walking is really great. You don't need to be at the gym and running and doing high intensity at this point in your life. Having said that, if you're someone that's already doing that, I wouldn't necessarily stop, but I wouldn't start that at this point in your life. I would probably be thinking about focusing on the strength and resistance training. And again, that doesn't need to be lifting really, really heavy weights. That can be taking a couple of cans of really heavy food up and down the stairs, a couple of bottles of water, these exercise hacks that we use, like, when you put the kettle on to boil, do a couple of squats, do 15 if you can. Just incorporate these tiny hacks into your daily life and it becomes routine rather than I must go and exercise, which can often be quite off-putting.
Are there different stages? I think you alluded to that in the first question. Are there different stages to menopause? Is it gradual? Do you notice a big change overnight?
Yeah, so I think if we think about menopause, clinically what we say is that the menopause is one day in time when we can retrospectively look back and say we haven't had a period for 12 consecutive months. After that time, you're postmenopausal. Before that, you're what we call perimenopausal, in this transition up until the last period. And symptoms are very, very individual and can change. I often call it a bit of a moving goalpost. So you may have one symptom one day and never have that symptom again. It may happen overnight and disappear overnight, and you may be left with a new selection of symptoms. And that's just as our natural hormone levels change, and partly going back to our first question about genetics and how we experience it personally. But you can have symptoms quite suddenly, because what we know about the perimenopause is that our hormone levels are drastically changing, sometimes to the point of going from normal to really, really high in the space of 24 hours and then back down to normal. So you can imagine those spikes and troughs can actually bring on those symptoms quite rapidly, but they can also resolve quite quickly.
Okay. How can someone spot the signs? And then the early signs, if you would.
Mm. So I'd say anyone, if we're talking about typical age ranges here rather than the earlier menopauses, what I would say is it can be really difficult to think about what symptoms could be menopause and what symptoms might not be. So really what I'd say from anyone from the early 40s, start to track your periods if you're not already doing that. Track your other symptoms. So track them from top to toe. What's going on for you? Do you think any of your symptoms could be hormone related? But I think it's really important that you track them for a few months, because as we know, our cycles change and our symptoms will change with our cycles as we are progressing through the perimenopause. So like I said before, you may have some hot flushes and then they may stop and you may get joint pain. That may stop. You may have insomnia or, really importantly, vaginal dryness. And those are symptoms that can come and go, can get better, can get a bit worse in this transition period. So really important to track them. And that will enable your healthcare professional to kind of look at those symptoms collectively and go, could this be perimenopause? Could it be something else? Or could it be a combination of both?
Can you talk to us about available treatments to manage menopause symptoms? This is both hormonal and non-hormonal.
Yeah, so it's really important when we think about treatments that all options are on the table and all options are discussed with you. But what we will do is take into consideration your past medical history, thinking about the medications you're on, thinking about how they might interact with a hormone treatment, thinking also about your family history, because that's also really, really important too. What we will then consider is either hormone replacement therapy, which we know is the gold standard treatment for symptoms of the menopause, or we will consider non-hormonal treatment. And really, the decision about one or the other is individualized, of course, but it's also based on your personal preference and your medical history. So we know that hormone replacement therapy is really effective, and the type that we give today is estrogen predominantly given through the skin because we know that's the safest way to use it, and a progesterone taken as a tablet at night, which is both forms are body identical, and all that means is that they resemble exactly what your body naturally has produced. And the beauty of that is that you're less likely to experience side effects, although not completely down to zero, but you're less likely to experience side effects. And we know that there's various doses, there's different preparations, and we know that adjusting that can make you feel a bit better. But I always caveat that with HRT is wonderful, but it isn't the golden bullet. It's not going to get rid of everything. So we need to be very mindful of its limitations, but also mindful that it can be really helpful too. And then we think about non-hormonal options, of which there are many. And these medications are mainly aimed at people who perhaps can't take HRT or who choose not to. So that might be because they've had a hormone receptor positive breast cancer or another medical condition that ideally we'd want to avoid using hormones with. And these medications typically treat individual symptoms of the menopause. So they don't treat the menopause as a whole. They can be really effective, and these are typically prescribed medications by your doctor. And then we move on to the other non-hormonal therapies, but we think about these very much in the same vein as everything, in that equal importance, really. So things like cognitive behavioural therapy we know is evidence-based and we know can be really helpful for insomnia. Thinking about acupuncture, thinking about, movement, yoga, Pilates, those strength-based movement exercises. And then obviously thinking about supplements, but we always think about supplements with the sort of caveat that we need to make sure that they are safe and that what you're taking is a good preparation and a safe preparation. And there are obviously lots out there and it's a bit of a minefield. So I would speak to somebody, particularly a menopause specialist, if you're thinking about going down that route, because we do know quite a lot about what's good and what's less good.
Can you give us an example of some of those supplements? Like what supplements would be useful during menopause?
Yeah, so depending on the person, particularly a magnesium glycinate could be really helpful for sleep, particularly if you're someone that's waking up, perhaps catastrophizing at night, feeling really worried at night. Magnesium glycinate can be really helpful. Magnesium as a compound, so magnesium malate can be really helpful for joint pain. So we often advise a kind of all-in-one magnesium tablet because it can help with a few things. I often advise a vitamin D. I don't think any of us get the right amount of vitamin D, certainly here in the UK. The sun isn't the right sort of sun ever. So a vitamin D supplement daily is really helpful because that will also help with our bone health too. And we know that vitamin D is really important for immunity and immune function. So I would strongly recommend that. And then other supplements really are based around what symptoms you're still having. So we know that there's things like lemon balm, for example, that can be really helpful for relaxing. It can help really enhance our GABA receptors, and GABA receptors are receptors that can help calm us down. So if we've got good GABA control, good calming, good parasympathetic nervous system, so that's the rest and digest side of our nervous system, that with a few different supplements can really be calmed down and can help relax anxiety, control sleep. So there's lots of tweaks and hacks, if you like, that alongside HRT or instead of can be helpful if you can't take HRT.
Fantastic. Thank you very much. And so this is not from any of our clients, but this is more something that we've observed. And it's why do you think there's no straight route to all available information about menopause? Why do so many women are still lost during this stage, or cannot rely on a single resource for all their information? Why do you think this is happening?
I think the menopause world has grown tremendously certainly in the last 5 to 10 years. And I think with the advent of social media, I think there's a lot of misinformation, unfortunately. So I think there's a lot of information out there, but women don't really know where to go for their trusted information. So podcasts like this, where you know you're getting evidence-based information, are really important. But I think because of that misinformation, there's the lack of knowledge and lack of awareness. And I think that's changing. Clearly, that's changing. And making sure that you can read around the subject and look at different sources of information and compare sources of information, because you may find two platforms say something completely different. And if that's the case, go and have a look at something else so that you can try and see if you can get the right information. But I think really the fundamental is that there's a lot of information out there. How do you navigate that information?
So I think we're not in the lack of information age, we're in the too much information age. So what 2 or 3 resources that you know to be reliable that people can go on for information about menopause?
So the two places I would actually look for are go to the British Menopause Society website, and have a really good look at the resources they've got available there, but also the Women's Health Concern website, which is the patient side of the BMS. And they have got some fantastic resources, videos, leaflets, fact sheets that is absolutely evidence-based. And that's what we strive to do. So I'm part of the British Menopause Society Advisory Council. And what we really try to do is get evidence-based information out as quickly as we can. We're playing a lot of catch up, as you can imagine, but as quickly as we can so that the information is out there. The other resource that I would really recommend is the website Menopause Support, because that is a wealth of information. And on that website, you'll find leaflets that you can download. And really importantly, there's a leaflet on there that contains a tracking symptom score. So you can track your symptoms really, really easily. And that goes back to what we were saying previously is about, knowing what's going on for your body and what's changing, and tracking it month to month can be really helpful.
Thank you very much. This is very useful. Okay, I ran out of questions. Is there anything else you would like to say as a kind of a distilled experience on the subject?
I think what we said at the beginning, which was really knowledge is power, and I know that is said a lot, but if we can start to educate our boys as well as our girls from an early age and talk about this openly. And my big passion, and I'm going to get this in here, is vaginal symptoms. Don't suffer in silence. There are some really great treatments out there that can be really, really effective. And we know that vaginal dryness, 70 or 80% of women going through the menopause will experience a degree of it, and some so much that they can't even put underwear on or can't move, can't work. There are really effective treatments. Please, please, please don't let it be a taboo, and please talk about it.
Thank you very much. Well, as a man, I certainly learned a lot during this podcast. Dr. Phipps, thank you so much. It's been an absolute pleasure. We will put a link in the description for your website in case anyone would like to get in touch.
Thank you for having me.
An absolute pleasure. Thank you very much.
Well, that was very useful, and I hope we managed to answer a lot of your questions. Actually, I'm sure we answered all the questions I had on my sheet. So if you did like the topic and you did get some useful information out of our podcast, please like, subscribe, and click the ding dong to get alerts whenever we publish a new episode. Thank you very much for joining us, and we'll see you on the next one.
Thank you.